Good evening, everyone, and thanks so much for joining us again for the 8th in our Menopause series of Restless Presents with our partners, My Menopause Centre. And on this occasion, as I'm sure you're aware, we're going to be looking at midlife leaks and how to manage them. So before I hand over to Helen, who will chair this evening's event, I wanted to remind you of a couple of housekeeping points. So please post your questions and thoughts in the chat function at the bottom of your screens, and feel free to post throughout the presentation. There will also be time at the end for questions. This event is recorded and we can mail it to anyone who's registered for it, along with links and other resources after the event. And it'll also be available on YouTube as well as in the menopause section of Restless. So I'd like to hand over to our panel chair, Helen Normoyle, who is co-founder of My Menopause Centre. Helen has held Chief Marketing Officer roles across the healthcare, beauty, broadcast, furniture and property sectors, and is a self-described women's wellness champion. Over to you, Helen.
Thanks a million, Aideen, and great to see you again. And good evening, everyone. And thank you again for joining our live event on midlife leaks and tweaks and how to manage them. Dr. Claire and I are delighted to be joined this evening by the founder of Physio Fast Online, our physiotherapy partner, Katie Knapton. Katie is a chartered physiotherapist. She's over 30 years of musculoskeletal experience within the NHS and latterly in her own private practice in West Sussex. She trained at King's College, followed by 2 years at Guy's Hospital. After that, Katie specialised at St George's Hospital in Tooting for 9 years, working alongside orthopaedic consultants and running a team of physiotherapists in the busy hospital clinic setting. She's been in private practice since 2002 and is passionate about quality and ensuring people receive accurate information about their specific conditions to determine the best course of management for optimal recovery. And this was one of Katie's key drivers for building Physio Fast Online. And Dr. Claire, you all know, she is the brilliant menopause specialist and clinical director of My Menopause Centre and my very good friend. So now, as we all know, there are lots of taboos around the menopause, but there are lots of taboos within these taboos as well. And for many women, midlife leaks fall into that category, but it's really important to talk about them and any issues that you have with bladder leaks or incontinence, because left untreated, they can really, as you will know, impact your quality of life, and you're not alone. It's estimated that around 1 in 3 women experience bladder symptoms related to menopause. And I read somewhere, Katie, I think from you, that it's estimated that around 80% of women doing certain types of sports can experience leakage as well. So we're going to kick off in a mo, but as Aideen said, questions are very much welcome. Just one thing to remember is that we're not permitted to provide any personal medical advice within the session, but can, of course, comment on general questions. And also, please remember that you should talk to your medical professional before acting on any information provided. So let's launch in. And Dr. Claire, let's start with you and that stat of 1 in 3 women experiencing bladder symptoms related to the menopause. So just why do women experience these midlife leaks and other bladder related symptoms and issues as they go through the menopause?
Yes, thanks, Helen, and good evening, everybody. And that 1 in 3, I'm sure it's an underestimation. When I directly question women coming through the clinic, I would say the vast majority of women are complaining of either waking up in the night, of leaking when they're walking or running. I think it's far more common than 1 in 3. So I think to understand why it's happening, let's just quickly recap what's going on through the menopause. So we know that through the menopause transition, a really important ovarian hormone called estrogen, the levels fluctuate in the perimenopause and ultimately drop, so that in the menopause, defined as 12 months of no period, the level of estrogen will be low and it will stay low. So bladder symptoms related to the menopause, a bit like vaginal symptoms, can actually start early in the perimenopause as those estrogen levels start to, on average, drop, even though they might be fluctuating. So the estrogen is so important for so many parts of our body, not least the vagina, the urethra, which is the little tube that drains the bladder itself, which is a little bit like a collapsed balloon that then slowly fills with urine, and the pelvic floor. And the pelvic floor, which I know Katie's going to talk about in a moment, but in a nutshell, it's the sheet of muscle and connective tissue that holds all your pelvic organs up. So by that, I mean the vagina, the cervix, the uterus, the bladder in front of the uterus or womb, and then the bowel behind it. So all of the tissue of all of that is really dependent on estrogen to stay healthy and functioning normally. So with the loss of estrogen, the urethra, that little tube that drains the bladder, can become more sensitive. The bladder comes more sensitive, so can start to contract or squeeze before it's really ready. And we know the pelvic floor can be affected as well, so everything can also have a tendency to head a bit south. And so the symptoms of having to run to the loo more often, having to run to the loo more frequently to pass urine, having leakage when you cough, sneeze, walk, run, having to get up and go during the night, pain passing urine also, so it can feel like you've actually got a urine infection, or can all occur as a direct effect of loss of estrogen.
So that it's really helpful. It's amazing just how fine-tuned our bodies are, aren't they? And how receptive they are to estrogen and the difference that it can make. And before we come to Katie to talk some more about this, are there other things that happen in life or around our body that can impact our propensity to suffer these leaks and these bladder leaks?
Yeah, no, absolutely. I mean, the first is just the fact that increasing years, aging also has an impact. So it has an impact on tissue, has an impact on muscle weakness as well, and the integrity or strength of the connective tissues holding everything together. And then there's pregnancy and childbirth, so that pressure on the pelvic floor, constipation we were talking earlier, which is incredibly common. So any straining or bearing down on the pelvic floor on a regular basis can induce weakness. So women who have chronic cough, so for example with asthma or chronic obstructive airways disease also, and sadly carrying a little extra weight around, again, anything that puts extra pressure on that pelvic floor. Some women have fibroids, big knots of muscle sitting in the womb also. So lots of other factors that can make it worse. Also, I'm sure we'll come on to caffeine can increase your bladder irritability, can make it more likely to contract. That list is not exhaustive, but you get the general gist. There are lots of factors that can have an impact.
Brilliant. Thanks, Dr. Claire. And Katie, you've got so much knowledge and insight based on all of the patients, you know, that you've seen and supported in your years of practice. And I know one of the things that is really important to you is to help people understand the language that they use to describe their symptoms. And we've chatted before around the importance of understanding when we talk about urinary incontinence and we talk about bladder leaks and we talk about, you know, people would say, I have to run to the loo, or I get to the front door and I absolutely have to go to the loo. That there's really helpful language to describe all of that. But maybe if we start on that key one, incontinence and urinary incontinence.
Oh yes, my bugbear. So as you say, I've treated a lot of patients and not necessarily their initial complaint was incontinence actually. So I'm primarily an MSK physio and happen to pick up incontinence as we go along. And that is because you do a safety netting question looking for any sort of more serious pathology. And you always ask, you know, any problems with your bladder or your bowel, any incontinence, and everyone goes, no, no, no. And then if you question further, they all can manage everything and they go, I said, oh, any problems when you cough? And they go, no, I'm fine, sneeze. And then suddenly someone will go, well, actually, when I laugh. So incontinence, the actual sort of prescription, you know, describing it fully and properly, it is the involuntary loss of any amount of urine, of wind, and of poo, feces. So it's any of that is not, you're not doing voluntarily, can be described as incontinence. So yes, we're talking about a whole scale. So someone go, no, well, I just have that sneeze wee and that's fine. And the rest of the time I'm all right. That isn't all right. You are showing signs of incontinence. And it's something that you can, the good news is it's something that you can really deal with and you can treat well. So the stress incontinence, which is that classic sneeze, cough, laughter, I'm not going to go on the trampoline, is the most common presentation. And the good news about that is it's also the most successfully treated with pelvic floor exercises. And then you've got your urge incontinence. So that is, yeah, putting that key in the lock when you're coming in from shopping and you suddenly have this overwhelming urge to go to the loo. And again, with some bladder training and work, in general, we can help that. And then you can have a mixture of the two. And the problem we have is the longer these things go on and the longer you ignore them, the more complicated it is and the harder it is to treat. So what we're hoping is that people listening to this today will actually suddenly think, oh, okay, or they know a friend who's talked about it. And you actually can start to engage, look up stuff, try and find the relevant information for you, or hopefully we can give you some tips to help you move forwards and actually try and get on top of it before it becomes so severe.
And we're going to come to tips and advice and all of this in a moment. But before we do, and before we come on to, you're going to help us understand our pelvic floor a bit better. Claire, maybe a word on prolapse and the impact of that as well, what it is and the impact of it.
Yes, yeah. So I spoke about the pelvic floor being a sheet of muscle, basically in that sits across the pelvis, a sheet of muscle and connective tissue that holds everything in your pelvis up. So pelvic organ prolapse is really where one or more of your pelvic organs slip down from its normal position. So that can be the vagina, and is very commonly the vagina. It can be the cervix. It can be the womb on top of it. So if you think of a stack of your vagina, the cervix, and the womb on top, any of that can come down. It can be the bladder heading south. It can be the urethra kinking and heading downwards also. And then it can be the bowel, which is tucked behind the vagina, pressing into the vagina itself. So if I was going to examine somebody, I might, for example, if you're taking a smear and you put the speculum in, you can see a bulge into the vagina of either the front wall or the back wall. And then you might see that the cervix is much lower in the vagina than it was previously. Again, generally because of laxity of that pelvic floor. And that itself can cause symptoms. So you might feel bulging, dragging sensation, a heaviness. Some women find it really difficult to open their bowels and empty their bowels properly, and have to actually physically push the back wall of the vagina to be able to empty their bowels properly. So it's really, it's not life-threatening, but it's really debilitating, and symptoms can be really bothersome. And you know, symptoms can worsen in the menopause due to loss of estrogen. And if you've got a really delicate vaginal tissue, because there's not enough estrogen, that bulging can be really uncomfortable, as the sort of, you can imagine the walls of the vagina sort of meet in the middle, and can be really uncomfortable with vaginal dryness.
Yeah, that does sound very uncomfortable. And hopefully if there's anybody on the webinar tonight or watching it later that recognizes that in the symptoms, hopefully the webinar tonight will help them. Katie, as we've discussed before, knowledge really is power. And we know that very many people don't really understand their anatomy. Understandably, not all of us have studied biology or are experts as you and Dr. Claire are, but you've got a 3D model that you're going to show us now, just to help us understand our body and how all the different parts come together.
Yes, so can you, is it coming up on my screen? So sorry, it's still very small on my screen, so it's very hard to see. Right, so this is a pelvis. So this is front facing, and then so you've got your spine there. So if you look inside there, that is your pelvic floor. Now, it's quite a complex, some people describe it as a hammock. I think actually it's probably better described as a spider's web, because it's quite intricate, it's quite clever, and it moves with you. And then if we look on the underside, you can see, so you can see your vagina, oh, sorry, vagina there. Where, oh yeah, sorry, I'm having to orientate myself, I'm so sorry. So vagina there and your anus there. So it's all very closely connected. And when you're sitting, that is what it looks like. So you sit on, your sit bones are here. at the back here. So sometimes, so there's always a bit of a tilt. Yeah, so that's why when we try and start getting people training, is we get them aware of where their pelvic floor muscles are. So sometimes you roll up a towel and you can sit on that towel along, so you can actually feel when you're trying to lift away, to really orientate yourself. And if you're really having difficulty, if you're used to inserting tampons, I sometimes get people to actually, you know, if you're happy to either insert a tampon and just try and grip that, or use your fingers just to feel what are your muscles doing, because I think it's really important. And I think we've also talked about names, and actually learning your anatomy, your female anatomy, is vital. So then you know what is hurting, what is sore, where the tissue doesn't feel quite right. And you really want to get familiar so that you, when you go to a medical practitioner, you can say, well, actually, it's my vulva that's really sore, or it is that something's wrong in my vagina, you know, so you know what you're talking about and not feel embarrassed. But yeah, so that they're amazing. It's an amazing system that works. But as you can imagine, some people talk about estrogen being like the water to a garden. And this area is particularly necessary to be well watered. So you're losing estrogen, so you're losing that water, and no wonder it suffers post-menopause. It's quite a huge problem. But people really need to get much happier with thinking about their female anatomy and not feel embarrassed about it, because there's stuff that we can do. I mean, as Dr. Claire will talk about in terms of actually having some, you know, estrogen, either local or actually HRT, which obviously we'll get into. But don't be embarrassed about knowing a bit more about your pelvic floor, how to actually contract them, how to work them, and engaging with it.
And I would just add to that, the anatomy can be confusing, and people very commonly say vagina when they mean vulva. So I would, if you're talking to your doctor, I always say just be as graphic as you can be. I would never be embarrassed. I was just about to say I'm unembarrassable, but I thought that might be too much of a sweeping statement. Your doctor won't be embarrassed. Just describe it as it is, basically. Don't worry too much. There are lots of diagrams on our website trying to make things clear, and I know on Katie's website also.
Yeah, and to that point, Claire, Katie's given us the link to a really good 3D pelvic anatomy video from the Continence Foundation of Australia. And Emma, thank you very much for putting that into the chat. And Emma's also put a link to bladder symptoms and to an article, a great article that Dr. Claire wrote. And there's a graphic in there that labels all the different parts of the anatomy. And as Katie has described, so hopefully those resources will help you and help you have better conversations with your healthcare practitioner. So Katie, now and Claire, now that we have that understanding of what causes these bladder issues, the different types of incontinence bladder issues that you can have, the role of our pelvic floor, I suppose the really important thing now is so what can you actually do about it? Because, and to get the ball rolling, I'm going to call out one of the questions that we got in advance, because I think it sums up very nicely the journey that somebody's been through, and we can draw it into treatment options. So this woman emailed us to say she's perimenopausal. She leaks pre and post her periods, a few days pre and post, but then it's not just leaking, it feels like it's flooding. She's tried, you know, physiotherapy, vaginal creams, and so with somebody on that journey and going through that, and somebody else here has asked a question in the chat to say they leak at night without knowing. Is that kind of bladder leakage as well? So I guess, Katie, based on your explanation of incontinence, would that be a small urine loss at night without knowing it? Is that in the same boat as well? And what can we do about those things? So Katie, do you want to get the ball rolling, and then Claire will come to you?
Mm-hmm.
Yes, so with the complicated, slightly more complicated presentation, I'd want to probably liaise with Dr. Claire about, but I would also be talking about, so when people say they've engaged with physiotherapy or they've done pelvic floor exercises, just want to check that they've actually had the correct help, so that they're engaging their muscles correctly, because we do find so many people, instead of actually lifting up, they're actually bearing down, so they're holding their breath. They're sort of really starting to push down and thinking they're getting it. And those are your classic people you see sort of contorting when they're doing their pelvic floor exercises. You shouldn't need to make any faces. It shouldn't be that sort of involvement of recruiting those muscles. Okay, it should be that you just work on trying to lift away. As I said, sometimes having that stimulation in that area, so having a towel along your pelvic floor or sitting on the corner of a bed so that you've got a little bit of feedback, so you're giving your own feedback and trying to lift away, will help give you the idea of what it should feel like. And doing normal breathing. You shouldn't be holding your breath when you're doing the exercises, so it should be a nice, relaxed, calm. And then it's trying to do your endurance holds and also your quick flicks. So those are the sort of normal stages. So we talk about, you know, you won't pee with the 10-10-3. That's from Elaine Miller, a quite well-known physio in women's health. And we know that they do make a difference. So it would be checking that you're engaging the muscles correctly, and then really just trying to find the best way to get you retraining them. So it would be getting you setting a reminder on your phone or using the Squeezy app. There's lots of stuff that's useful. And then if that is still a problem, then it would be bringing you in for a face-to-face, and then they, you know, we'd measure what's happening. We'd use a biofeedback machine to see how your muscles are recruiting or not, or an ultrasound to guide. And then obviously over to Dr. Claire, because there may be some input for some sort of HRT as well with this presentation.
And Claire, before we come, just one quick question, because Andrea has asked, as you were describing the actions, Andrea asked a question. Is it like a pulling in motion?
Okay, well, so I mean, we used to talk about trying to stop yourself mid-wee, but we don't really talk about that now. And actually find people recruit better if you say you're holding in a fart. So you're trying not to pass wind, and actually that tends to recruit the right muscles. So sorry, it's a little bit graphic.
Yes, and
Memorable.
Katie, can I just ask, because I missed the acronym, what was it? Something 10-10-3? Or
Oh, right.
Could you just explain that?
You won't wee with a 10-10-3. So that's 10 repetitions, 10 times, 3 times a day.
Say that again. You won't wee with a 10-10-3.
So it's 10 slow reps, 10 fast reps, 3 times a day.
Okay. And so what would you class as a slow rep?
So you're lifting up and you're trying to hold it for 10. Sorry. So it's an endurance one.
Okay.
So you tighten up as high as you can, and then you hold for as long as you can. You're looking to get to a count of 10, but you won't do initially.
Right. Okay. So you're doing 10 of those 3 times a day. And then what
and
about
10 quick flicks as well.
And then 10. So literally in,
so you
out. Yeah.
Squeeze and relax and fully relax. Squeeze and relax. Yeah. So it's the quick ones.
Yeah. So I'm sure somebody said to me that training your pelvic floor is like training for a marathon. It's that level of commitment. Do you think, is that a fair comment or not?
I think that's a bit harsh, actually. I mean, it really depends on what level you're starting from. But we know that just getting people to engage, to actively think I can make a difference, which the evidence is there that you can, and actually getting people thinking, more aware, and even just doing it a couple of times, although we'd say the ideal is 3 times, people can make a difference. If we see people who are just having slight problems, the consensus is that they make a difference within weeks, early weeks, 2 to 3 weeks of actually trying to do it. So, it is good outcomes from minimal, really, because it doesn't take any time. You don't have to travel anywhere. It's quite easy once you've got the hang of it.
Yes. Yeah, no, thank you.
So I think, Claire, thanks a million for asking Katie to repeat that, because I had to, I don't know if it's like menopausal brain fog or concentration, but I had to hear it repeated 3 times to kind of get it. And Katie, that description was very memorable. What you need to do. So that was fantastic. But that's what we need, because it has to be that simple and straightforward if you're going to build it into a routine. And it's so much easier said than done, isn't it, to do this? So what were your tips again for your mind, reminding yourself to do it?
Setting an alarm on apps. Yeah, the Squeezy app is free. I think that's free to download, isn't it? Or do you pay
it's $2.99.
2.99. Okay, yeah, I've heard lots of really good reports about that. Yeah.
Is that an NHS app, or is it a?
Yeah, if you're referred in the NHS, I think you can get it for free, but you can just buy it off any app store. Some people love it, and some people don't. But it certainly, I think it's quite helpful for those who like apps and things on their phones. Then it's great.
Oh no,
Brilliant.
thanks, Katie. Yeah, and then going back to the question, Helen, that you pulled in. So there is another hormone to consider called progesterone, and progesterone causes it really basically smooth muscle relaxation or reduces the tone of tissue. And so with that relaxation, sometimes I have seen, and I think there is evidence that that can make stress incontinence particularly worse, as again, that muscle is relaxing, and your progesterone levels are highest just before your period, and then it drops. And so I just wonder if that's something to do with, that is something that might be going on with the person who asked the question. And then just bringing in vaginal estrogens, because if you are experiencing bladder symptoms that are related to the menopause, particularly those irritative symptoms, the urgency, the sensitivity, the recurrent urine infections, the feeling you've got an infection but you haven't, using a vaginal estrogen can be really helpful. And you can use a vaginal estrogen either instead of or as well as systemic HRT. By systemic HRT, I mean the patches, gels, spray, tablets, and many women who are using systemic HRT also need a vaginal estrogen, particularly with sort of lower doses. I wonder if it's just helpful to quickly summarize types of vaginal estrogen that are available, because I have got a few examples here, not all of them. There is a nice cream called Ovestin cream that comes with an applicator. I haven't got the tube of cream itself, but you squeeze the cream into the applicator, pop it into the vagina and release it. Or if this is a bit of a faff, you have to wash it, you can just work out the dose and squeeze it onto your finger and use your finger instead if you feel comfortable with that. There's Vagifem, or the other make is Vagirux, which are little white pessaries that sit on these plastic applicators. Vagifem comes with an applicator for every single pessary, but Vagirux has less plastic, and you get 1 or 2 applicators and then a pack of pessaries. So that can be really helpful. And you're putting it into the vagina, remembering that the urethra and the bladder sit on top of the vagina. So the estrogen in the vagina is going to help the bladder also. There is a bigger, waxier pessary, more like a bullet. This one here, that's Invagis. They're okay. The only thing is, you can see they're quite big and they have quite a waxy, melty discharge. And then there's an S string. This is a vaginal estrogen ring. And although you might not like the thought of it, they're really good. They sit in the vagina at the top, releasing a small amount of estrogen the whole time. You can have sex with it in. You change it every 3 months. And that can be a really good way of giving a constant dose of estrogen. So systemic HRT might be helpful, but if you've got predominantly vaginal / bladder symptoms, a vaginal estrogen, I would always start with systemic HRT or even instead of. So that can be really helpful also in helping some of the incontinence that we've spoken about today.
So kind of 2 sets of really great tips there. So from Katie, the different types of exercises you can do to strengthen your pelvic floor. From Dr. Claire, a really good understanding of the different types of HRT and how they might benefit. We've got quite a few questions coming up in the chat and in the Q&A, and we will come to those in a moment. But before we do, Katie and Dr. Claire, any other tips, around lifestyle, other things that people should take into account that might help them?
Katie.
Oh yes, no, right. So bowels, constipation. We need to talk about constipation. We need to talk about loo positioning. So all of these things. So, you know, bearing down, putting too much pressure, we know overstrains your pelvic floor, and we've already, you know, talked about that. But there's been some recent research looking at long-term constipation and the effect that can have on your pelvic floor. And so people may be having regular movements, but they're not actually aware that actually they're constipated still. So they've got a bit of impaction. So it's really working out and checking that you're taking in enough fiber in your diet, if possible, bringing in prunes, your dried apricots, and really, you know, changing your bowel habit. And then there's also talking of your loo habits. So really, to evacuate your bowels comfortably, you really need to check that your knees are higher. So we tend to either you have a sort of poo stool, or you use a spare loo rolls under each foot, so you're just lifting that level of that, you know, a bit higher, so you're in a more comfortable position. And then it's really just relaxing and breathing normally and avoiding, you should not be having to bear down to poo. So those things are really important. So that is also looking at your general diet, checking that you're hydrated enough, checking that you're taking enough fiber. Exercise is also relevant. If you're not moving, your bowels won't move as well. So it's a really important thing that's quite often overlooked, because people just think, oh yeah, no, I'm going once a day, that's absolutely fine, or once every other day. But actually, you need to really look at it, because it puts pressure on all of those organs, and I think is commonly overlooked.
Yeah, and I just wonder if it's worth mentioning why pelvic floor laxity actually causes stress incontinence. We've talked about stress incontinence and urgency, and I know there can be many women have both, but they're sort of different mechanisms of action, aren't they? So Katie, do you want to just talk a tiny bit about stress incontinence and the pelvic floor, and why it's really important that we do strengthen the pelvic floor to help keep the urine in, basically?
Well, yeah, because if your muscles aren't functioning, you're not closing off that sphincter. So we really, it's just vital. So otherwise, people can, as things deteriorate, you get to the stage you just stand up and you just let everything goes. So, and we know, you know, by the time, so we talk about 1 in 3, don't we, over sort of 40 having problems with their pelvic floor. But, you know, by the time, if they're already having problems, then they're more likely to have far more significant problems once you're into your 60s. And actually, incontinence and pelvic floor weakness is not an inevitable thing with aging. We will get weaker, but if you started off with a low point, you are more likely to suffer more. So sorry, I'm not sure, has that covered the point you wanted?
Yes, yeah, no, I think it's just getting across, isn't it, that the pelvic floor acts almost like a shutter or a door. Yes. On the exit to the bladder. So with that muscle weakness from all of these things, like constipation that you didn't really realize that you had, so that weakness means that the shutter trying to keep the bladder door closed is weaker and more prone to open, which, as you say, then you can get to a stage where you just stand up, change position, and that shutter is not shutting, and so the urine comes out. Yeah, and so then there's the bladder irritability that's also important, and that's stopping the bladder from squeezing before it really needs to squeeze. A bit like as I said, the bladder fills up with urine a bit like a balloon, and then it gets to a critical point, and then it contracts and tries to squeeze the urine out. And then you can imagine that if you've got that going on, if that's happening too quickly or too soon, and you've got your pelvic floor is weaker, so the door is slightly ajar all the time, you can see how one makes the other worse. It's rarely just one issue. And so my other top tips was, so for example, use the vaginal estrogens, because they will try and get rid of some of that irritability. They'll manage the irritability. Caffeine is a shocker for, number one, it acts like a diuretic, so you make more urine. And then caffeine also acts as an irritant on the bladder as well. So the bladder tries to squeeze before it's been filled fully. So I always explore how much caffeine, and caffeine's not just in tea or coffee, it's in green tea, and it's in fizzy drinks that you might not even realize are caffeinated. So that's really important also, to really minimize your caffeine.
So brilliant practical tips there. And there's been one very relevant question, and there's a couple of other questions to you guys before we come to the general Q&A, but a very relevant one. How many times a day should you have a bowel movement? Is there a guidance in terms of what's healthy?
In terms of how many times a day, so at least once a day, but everybody's very different in their regularity. For some women will go to the loo twice a day, 3 times a day, but once a day is common. Katie, would you say the same?
Yeah, once or twice a day is probably seem to be the normal.
Yeah.
Great, thank you for answering that question. So we've had a really good view there of the range of different things and things to watch out for in terms of lifestyle, and particularly caffeine. Claire, thanks very much for calling that. Very sad, isn't it? Caffeine, alcohol, usually things we're not supposed to have, but they're very enjoyable. There's been a relevant, well, lots of great questions, but one here we were going to discuss as well. Katie, I know this is one that you think about too, and gadgets and devices. So a great question here from Una. Seeing lots of adverts on Facebook for a gadget with which to do vaginal exercises, and you can even play games in your phone with them. So slightly laughing face. Do they work, Katie? That is the $1 million question for the multi-million dollar industry.
It is it's a very profitable industry. They potentially may have a role. So they are in general quite expensive. So there are a number of just biofeedback ones, and I'm not sure there's a lot of evidence for them being fantastic, even though you can play games on your phone. What I would tend to advise is, as we've talked about today, is try and get yourself familiar with your own pelvic floor first. See if you can engage with your pelvic floor and feel that lifting sensation by actually tightening up your muscles yourself. And if you can do that, then try and have a go at doing the exercises regularly for a number of weeks. And if you're still not finding that you're getting anywhere, then rather than spending your money on a gadget, I would say perhaps you need to go and have a chat with a professional, and then they can advise you on what the best next stage is. Because at some stage, you are going to need to do these exercises yourself. And as I said, they're easy to do. You don't have to go quietly into a room and find that time to use your special new toy. You can just do them anywhere, any place. So, you know, the car's a great place when you're cleaning your teeth, all of those sorts of things. So they are really easy to do, and they aren't going to take you more than 5 minutes, and you don't have to set yourself up for it. So it's a big temptation, and they're really conducive to you spending money, these ads, and they make it look easy. You know, there's a temptation to throw money at it, but actually just take some time out, work things out yourself first, because actually you will be able to make the difference. The gadget's not necessarily. There is a place, especially for the muscle stims, that actually help the contraction, especially if you've really got a low level contraction. And actually, I think some of the biofeedback ones probably won't be, if you're really weak, they probably actually won't be any good, because you probably need the professional level stuff. So my temptation, well, my sort of thing is, nah. I wouldn't rush, especially not the really expensive ones. I mean, there's the key gel balls and things which can be useful, but you need to have got that basic contraction going first. And most people improve with the basic contraction and no toys.
Thank you, Katie. That was very clear. Thank you. I'm just going to run through some of the questions, and Claire, I'll start with you and a few of the HRT themed one, and there's a few people asking similar questions on this. So a couple around the topic of, I'm 3 to 5 years postmenopausal and I'm over 60. I haven't taken HRT. Is it too late to start it now, or can I start it now?
Yes, it's rarely. It's rarely too late to start HRT, and it's completely fine to start systemic HRT over the age of 60. If you start HRT under the age of 60 or within 10 years of your menopause, then there's a significant reduction in the risk of heart disease and heart disease related deaths. If you start HRT over the age of 60, you don't get that benefit, but it doesn't increase your risk of heart disease. With a vaginal estrogen, wow, you can start it whenever, as well or instead of systemic HRT. It's really, I don't think it's ever too late, because you hardly absorb any estrogen. The estrogen in your blood will still not be measurable as a result of using a vaginal estrogen. So most women, with very, very few exceptions, can take a vaginal estrogen. If you read the leaflet to the vaginal estrogens, it still gives you all the risks of swallowing estrogen. So blood clots, breast cancer, is all spelled out. And so many women are prescribed vaginal estrogens and they don't take them because they're terrified when they read the leaflet. So I know that is being changed, but it's a very, very, very slow process. So, and then just to finish, so if you've had breast cancer, there's a high chance that you can still use a vaginal estrogen unless you're on something like anastrozole or what we call aromatase inhibitors for treatment, which are designed to eradicate any estrogen in your blood. Women on those types of drugs are usually advised not to use a vaginal estrogen, although there are exceptions. So it may be that you need a chat with your breast surgeon or a menopause specialist, but you know, having had a diagnosis of breast cancer doesn't mean that you can't use a vaginal estrogen.
That's brilliant, Claire, because that was one of the questions that was in the chat as well. So thank you so much for addressing that. And another question that was in the chat was, do the vaginal estrogens, the different types that you showed, do they work in different ways or do they work in the same way?
Yeah, they all work basically in the same way. There's subtle differences in the estrogen. So some are an estrogen called estriol. And so the cream is estriol, which is one of the estrogens in our body. The vagifempestres are estradiol, which is another type of estrogen in our body, but they basically all work in the same way. The cream, I think, is really good if you're having painful sex. I know we're not talking about that this evening, but the cream's quite good because you can use it at the entrance to the vagina, where it can just soften unstretchy tissue if you've lost some of that elasticity and sex is particularly painful. But in terms of bladder, they're all much of a muchness.
And then another age-related question to HRT, Claire, from somebody who's soon to be 60 and who's been on transdermal HRT since she's had a hysterectomy 9 years ago, and this has really worked for her, but her GP doesn't want to prescribe even a low dose for her anymore. Is her GP correct in this recommendation?
Yeah, so there's no arbitrary age cutoff. To Katie's shaking her head also. Yeah, there's no arbitrary age cutoff. So you don't have to stop HRT at 60, 65. You don't have to stop it at 70 or beyond if you don't want to, as long as you accept that very small increased risk year on year of breast cancer, and it is really small. So I would ask the GP exactly why they want you to stop it, because it may be that you maybe need to speak to a GP or just have a look at some of the evidence yourself and just ask what their reasons are.
Yeah. Very good, Claire. Thank you. And another vaginal estrogen related question around Gina.
Oh, yeah.
So maybe if you, Susan is calling out that it's a new product, maybe if you just give a bit of context on Gina, Claire, and her question then is it any good, or are we better going to see our GP for proper hormonal products?
Oh yeah, no, great question. And there is information on our website on Gina. I think I made a video clip. Gina is essentially Vagifem. It's exactly the same. It's 10 micrograms of estradiol, which is exactly the same as Vagifem or Vagirux. It's more expensive if you buy it over the counter. So a box of 24 pessaries is around £30 as opposed to a prescription charge of £9.35. The only thing with Gina is because you're getting it from the pharmacist and not a doctor, they've got really strict criteria as to who they're allowed to sell it to. So, for example, they can't sell it to you if you're under 50 and if it's within a year of your last period. It's absolutely fine to use Vagifem or Vigirux or any vaginal estrogen if you're under 50 and if you're in the perimenopause, you're still bleeding. It's just for safety, the pharmacies have set criteria, strict criteria as to who they can sell it to. So it's actually the same as the stuff you can get on prescription. It's just more expensive, but it's more easy to go and buy it than get a doctor's appointment, sadly.
Thank you, Claire. That's very, very clear and helpful. Again, there's lots of HRT related questions in here. There's a couple around endometriosis. Actually, there's one in here, Katie, I'll come to you. I think this is back again. Is leakage at night the same thing as general bladder leakage or incontinence?
Yeah, I think that would generally fall under the incontinence. It's not normal at any time to have leakage without, you voluntarily doing it. So yeah, so that needs to be treated as incontinence and start looking at developing a pelvic floor regime, as we all should be doing, even if we don't have any signs of incontinence, really. If we want to stay continent, we need to work our pelvic floor because they're muscles, and it ties in with the whole sort of strengthening that we should be taking on, especially perimenopausally and menopause, post-menopause. Our fitness is really important, not just our pelvic floor fitness, our general lifestyle fitness and well-being. So you can, engaging in some strengthening activities is vital. The only thing we were going to cover that I know we haven't, and I'm not sure if anyone's mentioned, is about these sort of urge incontinence, which can be quite disabling, and talking about, so you can in general retrain your bladder. So people commonly, and you hear people say it to their children all the time, and I'm probably sets us up in a bad way, is that, oh, just go to the loo in case. Oh, mum, I've just been. Oh no, but just in case. And then once we head into our 40s, we start doing that to ourselves. Why do we do that? Our bladders are designed to hold a certain amount of urine, and actually sort of voiding without needing to leads to problems, okay? So we really want to get out of the habit of the just in case wheeze, because it can trigger you up to have a huge problem later on. And, urge incontinence can be a real issue for people. So you need to, that's when we talk about, doing those bladder diaries, avoiding those drinks that Dr. Claire's already spoken about. It doesn't mean restricting your intake of fluids, though. That is not going to benefit you in any shape, way, or form. The only time we would say that to reduce your intake of fluids is probably after 8 o'clock in the evening, because if you do take in vast amounts of liquids after that time, you may well have to get up in the night, but that's because you have a full bladder. So, thinking about training your bladder is something that's really worthwhile. There are some tips if you're really overcome with that urge incontinence. I don't know if you remember when you were a little girl, you used to hold yourself. Obviously we don't tend to do that, but actually that stimulation, that actually holding, can help control it. So we talk about sitting on the arm of a chair, and letting that urge die down, and then actually working on some pelvic floor exercises can then help you get control so you can get up and move on. So there are lots of other little, depending on how you're presenting. I had a patient who had got to the stage when she was dog walking that she suddenly had to go for a wee in the middle of the woods, and she couldn't quite understand it because of course she'd done the precautionary wee before she'd gone, and then we just talked about ways of managing it. She'd lean against a tree, she'd get control, and she'd then work on her pelvic floor exercises, and now she's back to normal. So there are ways around this. This isn't something that you have to accept, but please avoid that I'm going to have a wee just in case.
Yeah, they're great tips, and also very counterintuitive, because we call them tacticals at home. Get the kids to do a tactical before you go out, and also not reducing, staying hydrated, I suppose. Now, a couple of there's lots of HRT questions, and we'll try to come to as many as we can before we close, but we'll focus in on the ones related to pelvic floor. And Emma can maybe link to the HRT event that we did last month, where I think we've covered a lot of the questions that are coming up. A great question here around prolapse. If prolapse starts to become external, is it too late for exercise?
Oh no, that's a really good question, and I'd really like to talk to Katie about this as well, because so many women I speak to stop exercising when they start having bits of urine leakage, which is obviously really distressing. But just to answer that question first, so by prolapse becoming external, that implies that either the vaginal wall is bulging so much that you can see it on the outside, or the cervix is coming directly down so you can see it on the outside. So it's absolutely fine and indeed incredibly important to carry on exercising. You just have to be really careful about what you do. So you might want to, while you're waiting to have that managed, because there are many ways of managing that problem, you might want to avoid too much jolting, which might just be very uncomfortable. So swimming, anything where you're sitting down on a static, on a bike, you know, the cross trainers where you're avoiding that up down, the banging movement that force things to come down. So I've got a ring pessary here, which is one of the really straightforward, easy ways of managing prolapse. So if your prolapse is coming down and you can feel it or it's uncomfortable, one of the ways of managing it is by getting your, sometimes GPs will fit them, or a referral to gynecology to fit a ring pessary, which somebody made a comment earlier about a moon cup. It's a bit the same. So you squish it up, insert it into the vagina, and then it just sits at the top of the vagina, resting on the pubic bone, and that can just tent everything up. So that can mean actually that if you do want to do some gentle jogging with really supportive trainers, preferably not on concrete, on a softer surface, that having a ring pessary fit might just mean that you're comfortable enough to be able to do that. So very much in a nutshell, ways of managing prolapse. So it's pessaries that hold it up, or surgery is an option, which you would discuss with a gynecologist what your options were for that.
And another prolapse related question. So from somebody who's now 62, they have bad prolapse, but they have had endometriosis. So their question is, would estrogen help them?
So estrogen can help the symptoms of prolapse, but unfortunately estrogen doesn't really significantly help prolapse itself because it's far more of a physical thing. So if you've had endometriosis, you absolutely can use vaginal estrogens, but I wouldn't necessarily use it hoping that it would make the prolapse go away. And if your prolapse is bothersome, I'd be asking your GP for a referral to gynecology. You would see a physio first, because physiotherapy can help to a degree, depending on how bad your prolapse is. And then if physio hasn't helped, then that's when they usually progress to surgery.
Yeah, so I totally agree. And with the mild to moderate prolapses and some of those that respond really well to the pessary, they also still need to do pelvic floor exercises. It doesn't get you out of any of it, and you actually can improve it. So it's all, again, about that comfort, feeling controlled, and not ignoring. And majority, certainly locally to me, the GPs do fit the pessaries, and we've had some really good results working alongside.
Katie, what do you say to women who've started to leak when they're jogging or running?
Well, ideally, we say that that leakage is showing overload. So, and like any injury, overload is not a good thing. So we'd get them, if they say they can run 10 minutes without leaking, But if they go up to 15, 20, it will start to leak. We'd say, right, let's stick to that 10 minutes and then spend the next 10 minutes doing some other exercises that don't bring that on. And whilst you're then also engaging with your pelvic floor. And depending on that person, hopefully we can normally get through that, then we can gradually progress. So it is like any sort of loading program, really. So if they're going to leakage, they're overloading their pelvic floor and their pelvic floor isn't coping, so it's not really doing them any good.
Thank you.
Karen, we're in the last couple of minutes of the webinar. Another age-related, bladder-related, HRT-related question here. Someone who's read recently that using systemic HRT long-term over the age of 60 can cause incontinence and bladder symptoms to return. Is this true?
Oh, I haven't read that. No,
Yeah.
I would say no, it's not true, actually.
Yeah. Good, thank you. Very clear. And then a very practical question here: are prescriptions for HRT free if you get free prescriptions over the age of 60?
Yes, they are, absolutely. For all HRT and vaginal estrogens. Yeah.
Perfect, very clear. Question here: would exercises still help following rectal prolapse surgery? This lady's mum has had a procedure recently, and post-surgery now has fecal incontinence. She's 85.
Yeah, I mean, age is no limit. It depends on how radical the surgery is, and obviously we don't know about that. But in general, we would say that it's certainly worth your while engaging your muscles and trying to strengthen them. So, pelvic physios treat, there isn't an age limit, and there are, definitely, we've got lots of clinical evidence that 80, 90-year-olds can make a difference. So obviously it's easier if they're more aware of their pelvic floor earlier, and the earlier you get the training in, the better. But yes, it's certainly worth a shot. You've got nothing to lose by engaging and trying to activate the muscles.
Thank you. I think we've covered most of the questions. There's still a few outstanding. I'm just scrolling through them. While I'm doing that, Claire, we've had several questions around using HRT and will it help with loss of libido? So while I'm checking for that, if you could cover that.
It's worth doing your pelvic floor exercises also to help libido, make sex. It helps the sensation during sex. HRT does help libido. So just estrogen and progesterone, normal systemic HRT can help libido. Some women then also need a tiny bit of testosterone also, and testosterone is available on the NHS, but it has to be initiated by a specialist. So before I start testosterone, I always check a baseline testosterone level just to make sure that the level isn't already raised. There's no correlation between the level of your testosterone and symptoms. And then testosterone can be added, but it's we've done 2 webinars on libido and menopause, and while testosterone can give marginal changes, the sex therapists talk very much about the challenge of sex and libido in the long-term relationship. If you've been married for 20 or 30 or 40 or 50 years, it's working hard to keep it fresh. And testosterone can give marginal benefits, but it's a bit like working your pelvic floor, isn't it? It's very rarely just one thing that's going to sort it out. Katie?
No, well, can I ask about, so there is some talk about testosterone helping with strengthening alongside estrogen, in terms of when you're exercising, it helps promote muscle strengthening. Is that also part of that?
Yeah, there's evidence. You'd never prescribe it for that.
No.
The issue is that the evidence with regards to testosterone is pretty poor across the board because people haven't done the studies. But in theory, then it can help support muscle strengthening exercises. But
I also concur with, yes, you're doing your pelvic floor, and strengthening your pelvic floor will help with your intensity and enjoyment of orgasms and sex. So yeah, absolutely.
Brilliant. And I think Emma's posted into the links, posted into the chat, some of the links to some of the shorter videos. I know one of the really popular ones is around lubes and sex toys for use in the menopause that kind of help with that enjoyment as well. So I'll take this as the last question, and apologies to those whose questions we didn't get to, but we tried to get to as many as possible. So this is from someone who's joined us this evening who's 47, perimenopausal, and very unfortunately she's experiencing severe bladder cramps, but only while running, and each attack followed by a few days of urinary frequency and nocturia. Her GP has ruled out a UTI. Could it be related to perimenopause? And if so, what can she do? She's had to stop running as the risk of the pain is too severe.
Oh gosh, that's interesting. Poor you. Yeah, there could be lots going on there as well. Katie, I'd really like you to answer this also. I'm just wondering if it could be muscle spasm actually, or bladder spasm even. I mean, certainly it would be worth trying a vaginal estrogen and seeing what's going on there. It's quite an unusual problem. It's not something that I have heard many women complain of. Katie, do you have any thoughts?
And no, I think we'd really need to go into a little bit more history with that, because it is a slightly interesting presentation. And again, it could well be something to perimenopausal, but we'd probably want to cover that if there are any other symptoms that haven't been uncovered, whether you've had enough information, because just with running is quite unusual. So I'd expect a little bit more going on than that.
I would definitely go and see your doctor, because you'd want to check a urine sample. I hear you say there's no infection, make sure there are no other cells in the urine. And I think if it's really bad, I'd want to know whether it's going on at any other time as well, or if it really is just running, and what the bladder symptoms are around the running. Are there bladder symptoms at any other time? So it's quite tricky to give a full answer, but I would definitely go and talk to your doctor about that.
Yes, and then definitely fill in your health screening, your sort of menopause screening form, and perhaps do a bladder diary potentially if you need to take some more information, if you find the GP isn't perhaps being that good at listening to the whole story. And maybe then you might find that you've gathered a bit more information to make it clearer for them as well.
Brilliant, thank you. Emma's posted lots of links to various HRT resources, which hopefully for those of you who still have HRT questions, they'll help. So Katie and Dr. Clare, thanks a million. That was hugely informative. And Emma, thank you so much for being so busy at putting all of those links into the chat. And Aideen, over to you.
Yeah, and huge thanks from me and Restless also for such an interesting and very, very helpful event. Lots of useful tips for everybody. And as always, it feels like there's so much more that we could cover here. So once again, just a reminder that this event was recorded. We'll share a link. It will be mailed to you and to everyone who registered this evening, whether they attended or not, along with all the links to the other resources that were shared too. It'll also be available to view on Restless YouTube channel, as well as within our menopause section. And if you haven't seen any of our previous menopause events, you can find them here too. Thank you so much to our partners, Helen and Claire at My Menopause Centre, and thanks very much to Katie as well, and of course to all our members and to everybody else who joined this evening, and for all the great questions and comments that you shared with us. And that's it. Thank you all, and enjoy the rest of your evenings. Good night.